Hello everyone, welcome. Pleased to meet you. My name is Sean Van Hoof. I'm the Director of Sales for Sterile Care. I'd like to thank you for joining the webinar today, Reducing Alteplase Use in Dialysis, with our special guest, Dr. Ouellet from Quebec. We will be going through a brief overview of Kite Lock given by Karen, who is our CEO at Sterile Care, and then we will follow up with the information that Dr. Ouellet will be sharing with us. I please ask that you do mute yourself for the call. If you do have any questions you'd like to place in the chat room, please feel free doing so. There will be about as much time as we can give at the end of this presentation to discuss questions and answers that you may have given this presentation. So without further ado, I will hand this over to Karen. Karen, if you could do a brief introduction to yourself and then go through your portion, that would be great. Thank you.
Thanks, Sean. Welcome everybody to our webinar on reducing alteplase use in dialysis. I'm going to spend the first portion of this webinar just talking about intraluminal science and try to explain why we are seeing some of the results that we're seeing with the implementation of Kite Lock. Prior to starting, I myself and Dr. Chantal Innes are the founders of Sterile Care. We have been living inside a CVAD or venous catheter for the last 9 years. And Chantal, as a scientist and a clinical pharmacologist, has really dug into the science and the dynamics of what's happening. So with the practical use that I have from my nursing experience, we're going to deliver what we've learned and the science intraluminally. Everything I say is backed up by science. If it's not, I will let you know that it's methodology. And if you have any questions on the data that I'm referring to, please let me know and I can share that with you. Points of discussion on my part will be to review the science of the intraluminal triple threat, how it impacts outcomes. I'm very passionate about antibiotic resistance, so I will touch a bit on the new era of risk related to that, as well as COVID-19. Then I'll get into the current evidence that we're seeing with the implementation of Kite Lock. And then I want to talk briefly about expert opinion, being that we have a lot of experts on the line today. So anytime we implement a new technology and try and change practice, there's some sort of protocol that we go through in order to make those choices. So for today, we're going to be talking only about a catheter lock solution and its impact on the intraluminal aspects of a CVAD. So it's important that we look at the mechanisms of action. Is the lock solution a device versus a drug? That has an impact. As a device, the lock solution only works on the inside of the catheter. It has no extraluminal or systemic capabilities. And if it's a drug, it can work on the intraluminal as well as the extraluminal. The reason why that's important is when you're looking at your patient population and the evidence that's being released, you can interchange patient population evidence if it's a device. So whatever is happening in the catheter in a dialysis patient or an oncology patient will be similar because it only impacts what's going on in the catheter. If it's a drug, then it's important to consider the outcomes in the patient population because the different disease modalities will impact how that device is working. So of course, before we dive into putting this into a patient, we have to understand the anticoagulation capabilities of a lock solution, the microbiological assays, MIC, MBCs, and MBCs, which I'll talk about in a bit. And this is an aspect that is often overlooked or not reviewed, so I'm going to dive into this portion a little bit more. And then the science on biofilm. I've been studying biofilm for 9 years and I'm learning something every day. It is such a complex entity that I think it's really something that as clinicians, we need to spend more time to understand exactly what it's doing and how it works. And then we'll talk a bit about clinical evidence and patient outcomes. One thing that I think is important to point out, I sat on the steering committee to develop the Canadian National Guidelines for Vascular Access and Infusion Therapy. And in order to do that, we had to read all of the different guidelines that were out there internationally to understand what had been done before while we put ours together. And what surprised all of us on this committee was that majority of the decisions that we make for clinical practice are based on expert opinion or consensus. So although we drive new technology based on what the evidence says, a lot of times what we actually do is based on what the experts say and the consensus. So with that in mind, we're going to deliver the science, the evidence, and hopefully we can come to a consensus on whether kite lock is impacting some of your clinical outcomes. Of course, we all know the problem that comes with CVAD complications. They're related to infections and occlusions. We are very proud to say, as Canada, the infection rates in the dialysis patient population is significantly lower than other countries, sitting at 0.25 infections per 1,000 patient days on average. And although that is an extremely low number, it still equates to about 11 infections and 1 to 2 deaths per day. So there is still room for improvement to get to that ground zero that everybody strives for. And it's also important to point out that with the growing resistant organisms that we're seeing, that there is an increasing rate of these infections being caused by superbugs. It's reported that CVAD dysfunction occurs 20 to 40% of the time with these CVADs. And when it comes to cost, we know that an infection in Canada costs around $15,000 per infection. That's only the direct and variable costs. That does not include fixed costs. So the Canadian healthcare government spends about $1.2 billion a year treating these infections. And although our infection rates are low in dialysis, we're still spending about $60 million a year to treat these infections. Now, when it comes to the cost of occlusions, we have a really big gap of understanding because this is not data that we normally collect. All we can really mark the costs on is our Alteplase costs, which we know are high at $65 a dose. And for some reason, they're growing exponentially every year. And we also know, according to some of the clinical data in Canada, that a CVAD line change is about $1,200. So what can we do to impact those costs? We know cost drives care, so it's important that we drive the cost down. So let's go back to the basics about interluminal activity and how lock solutions combat that activity. So I think we've heard this many times about the triple threat inside a central venous access device. And in order to decrease complications, we have to stop all 3 of these gears from being inside these catheters. We have to stop the rate of clots that are occurring. We have to stop the amount of bacteria that are getting inside these CVADs. When bacteria does get inside these CVADs, they very quickly develop biofilm. Biofilm has a sticky surface that allows things to adhere to it, like blood components that cause clots, and then the gears just keep going. Now, biofilm strives on plasma proteins, so if clots are present, it's going to proliferate and grow some more. So when you're looking at a lock solution, if you want to reduce and impact both your occlusions and your infections, it's very important that you stop all 3 of these gears from moving forward and take them out of the equation. Now, we all understand clots and we all understand bacteria. What is, again, one aspect that we have spent very little time in or is misunderstood is biofilm. So I'm going to spend a little bit more time on that and show you how biofilm is not just about infections, it's about occlusions as well. So again, in order to stop that 1 gear of clots from being in the equation, we have to use an anticoagulant to prevent the clots from forming. And if we can't, then we have to use a thrombolytic to stop the clot or to dissolve the clots that are occurring. We know that the international trend and recommendation is to stop using heparin. It is now understood that the risk of using heparin outweighs the benefit, and there's a global movement to stop using heparin as an anticoagulant. So what you have left is citrate and tetrasodium EDTA. They are both chelators, and how they work is they latch onto calcium, take it out of the equation so that it stops the coagulation cascade, because calcium is a key element in the clotting factors. Now, when it comes to citrate 4%, it has a low binding affinity for calcium, which means that the calcium has to be available in a structure that it can grab onto it and hold onto it. And because it has a low binding affinity, the way the molecular structure is that it has the capability of releasing that calcium that can't hold onto it tightly. When you looked at the published literature, even though we try to get away from heparin and in dialysis have moved to citrate, published literature shows that citrate is not effective as heparin. In the one study done by Hendricks, it showed a 14% occurrence of non-occlusive clots in citrate compared to heparin at 7%. Then if you look at tetrasodium EDTA, It has a strong binding affinity, and the way that the molecule is set up, when it grabs onto that calcium, it looks like a claw of a crab. It grabs on and it holds onto that calcium and it does not let go. In this published data, it does show that tetrasodium EDTA has 10 times the stronger anticoagulant capabilities than citrate. Now let's look at microorganisms and biofilm. When you're looking at your lock solution, again, in order to take out that equation of bacteria and biofilm, your lock solution has to be effective against gram-negatives, gram-positives, as well as yeast. And it also has to be effective against the bacteria in a planktonic or free-floating state, as well as that sessile state, which is that hardy state of bacteria that's found underneath that biofilm or that slime. So when you're looking at your lock solution, it's important that you look at the microbiological assays to make sure that it can do all of these different elements of bacterial strains, as well as bacterial states. So biofilm has been around as long as bacteria has been around. Again, biofilm is that protective polysaccharide slime that sits over top of the bacteria. We know that when bacteria starts to colonize, within 12 minutes, it starts to form this slime or biofilm. According to the Kidney Disease Quality Improvement Guidelines, or KDOQI guidelines, it quotes, CDCs routinely develop a biofilm on their inner surface, often with 24 hours of insertion. What's surprising to me is these guidelines mention biofilm a lot as being a contributing factor, and like other guidelines, that's as far as it goes. It doesn't talk about how we get rid of that biofilm, so I think that's another level of clinical data that we have to start focusing on to make sure that we're impacting this biofilm. So the impact of biofilm is that antibiotics cannot penetrate it, so they can inhibit it from growing, but the risk of that infection or that occlusion will remain because antibiotics cannot get rid of biofilm. We know biofilm is responsible for up to 80% of infections related to the central Lyme because it's a continual source of bacteria. And we also know that underneath that slime, the bacteria are very smart, and they do what we call quorum sensing, where they share the genetic information on how to be resistant against antibiotics. Therefore, biofilm is an important source of superbugs. And we know that biofilm fragments, which can often happen because we encourage an aggressive flushing technique. So if any of those biofilm fragments are released into the patient's system, it can cause metastatic infections such as endocarditis. And what we also know, and one of the reasons, again, the risk-benefit ratio for heparin, the risk is bigger than the benefit, is that we know heparin stimulates biofilm formation. So here's a visual, and in our water pipe systems, in all of our areas that we live in, we know that over time, biofilm will occlude our water pipes. So we spend millions of dollars a year trying to clean up these water pipes with different solutions. So why would it not be the same in a CVAD? We know that bacteria is in there. We know that the biofilm is growing. So you probably will have layers of biofilm and clots inside that CVAD, which are causing occlusions. So just a recap and a visual of how biofilm is produced is you get these planktonic state cells that enter inside the CVAD. They mobilize themselves and attach onto the wall of the catheter, and from there they start to grow and secrete that sticky slime that protects them. The bacteria become sessile or dormant underneath that slime, and they continue to grow until that biofilm becomes larger and larger, and at some point the biofilm will disperse, open, the bacteria will go back inside to the interior of the lumen. It then becomes active bacteria if it's pushed into the patient's system. Depending on how their immune system is, they may or may not be able to counteract that bacteria, and they may or may not get an infection. Or that bacteria will grab onto that wall and start the whole process over, and you will get a continual growth of biofilm. So when you're looking at your lock solution, this is where it's really, really important to understand its microbiological capabilities. We are well known about the MIC concentration that we talk about, which means minimal inhibitory concentration. What that means is your lock solution, whether it's an antibiotic or not, when it's put inside the catheter, it will inhibit the bacteria from growing and inhibit the biofilm from growing. But once that lock solution is removed, that activity will restart again. It does not kill it or it does not eliminate it. When we see MBC MBC concentrations, that means what is the concentration to kill the bacteria on contact. So if your lock solution is able to kill the bacteria, it won't allow it to grow and the biofilm will not be formed. So it's important that you can kill the different strains of bacteria that are entering that CBAD. But when the lock solution is not in there, it allows the biofilm to form. So it's important that your lock solution also has MBEC, minimum biofilm eradication concentration. So when the lock solution is sitting in there, it is able to eradicate any of the biofilm that may build up. It's important to understand that even when we do culture and sensitivities, and we know that that line has an infection and it pulls out one strain of bacteria, that it may only be pulling one strain of the planktonic cells, but it may not be pulling all of the strains of the bacteria that are actually in this biofilm. And it is known that these biofilms often are multi-species. So it's important to understand when you're using those antibiotic locks, which I'm really passionate about not using them, that we don't create resistance and that our lock solution can actually eradicate that biofilm and get rid of it entirely. So the antibiofilm lock solutions that are on the market, the ones that prevent biofilm because they inhibit or kill the bacteria are taurullidine, citrate at 4%, and EDTA at 4%. It's also important to know that the studies out there show taurullidine has an affinity to kill the gram-negative bacteria. Citrate has an affinity to kill some of the gram-positive bacteria, not all of them, whereas tetrasodium EDTA has shown its capability of killing the gram-positives, the gram-negatives, and the yeast. And because these are gram-positive or gram-negative specific, we have seen the evolution of these lock solutions combining both the citrate and taurullidine, trying to be able to go against both the gram-positives and the gram-negatives. And next, you need to make sure that your antibiofilm lock solution can eradicate that biofilm. And tetrasodium EDTA is the only lock solution on the market today that shows its capabilities of eradicating biofilms of all bacterial strains found in CBADs, including those strains that are resistant to antimicrobials. And again, it's important to understand that the chelators, citrate and EDTA, only have an intraluminal activity. They are not systemic antimicrobials. Then we have our thrombolytic or Alteplase, which although it wasn't designed as a lock solution, has evolved to being used as a lock solution. We know a thrombolytic is used to break down the fibrin threads and dissolve a clot. But we have come to the place where it's become a desperation drug that we go to using TPA just because we're desperate to get that CBAD to function again. And we're using it more as a treatment and prevention mode when it really doesn't have that capability of preventing. It only has that capability of treating an existing clot. So if you're using Alteplase and it's not working, is it because the dysfunction is not related to a clot? Is it related to biofilm? Or is that clot covered by biofilm so Alteplase can't get at it? Or if the Alteplase is not working and you know that you've cleaned up that interior of that catheter, is it because it has nothing to do with the inside of the catheter, it's to do with the outside of the catheter? So these are really important questions that we're asking ourselves. Instead of just grabbing that Alteplase and using it, are we using it properly? And if it's not working, why is it not working? So here's a visual of a lock solution, and I like to show this because although it's a simple plastic catheter, the complexity of what's happening inside that catheter is quite large. So again, we need to make sure that when we're going after the lock solution, that it has the capabilities to kill the gram-positives, the gram-negatives, as well as the yeast. If it doesn't have the capability of doing all three of those and you leave some bacteria in play, that bacteria is going to form the biofilm. If your lock solution does not have the anticoagulant capabilities, you will get clots that form, and that's when you need to use some Alteplase to get rid of those clots. When the catheter does not have a lock solution in it and it is being used for treatments such as dialysis, you may get clots form during treatment. So when you go back to locking that catheter, you may need to use a dose or two of Alteplase to dissolve a clot that may be present. But if you are not getting rid of that biofilm that could be covering clots, you're still going to have CBAD dysfunction occurring. So it's important that we get rid of that biofilm so that it can't put more bacteria into the system that can cause infections, and that we get rid of the underlying and last element that could be causing these occlusions. So just a moment on the new era of risk. Prevention is more important than ever. We really truly need to stop these infections. Every single one of us has to do our role in saving antibiotics and only use them when we need them. And it's important right now that we keep these complications from occurring so we can keep these at-risk patients like dialysis patients at home instead of in the hospital where they're more exposed to the coronavirus. So this Canadian antimicrobial resistance surveillance report that was released in 2018 showed that 1 out of every 180 people admitted to the hospital had some sort of antimicrobial resistant infection, and that 1 in 5 patients died of these infections. And although we are dealing with a pandemic and the coronavirus, which is very horrific for all of us in many ways, in 2018, just related to antimicrobial resistant organism infections, we had 14,000 deaths in Canada in 1 year in 2018, and that number is growing every year. So that's just to put some significance to antimicrobial resistance, and that all of us need to do more in trying to stop this next slower moving pandemic. Now, Laurie Burrows is a Canadian microbiologist out of McMaster University who released this publication, news article back in April. And what she said back then, when there was only 120,000 deaths related to COVID, now I think today we're sitting at 1.65, that if we don't do something about this slower moving pandemic, by 2050, there are to be 10 million deaths per year related to antimicrobial resistance. But because of COVID-19, because of the antibiotics that we are throwing at these patients, even though we know they don't work against viruses, and because of all of the antimicrobials that we're using that contribute to resistance, either because they don't work at killing bacteria, they only create them to be more resistant, hand sanitizers, all of those different things. We think that this 10 million by 2050 is going to be moved further in advance, and it will be in our lifetime that we won't have antibiotics to go to. So each one of us has to be more diligent and more judicious with the use of antibiotics. So let's talk about the next generation lock solution, which is KiteLock. KiteLock is made of tetrasodium EDTA, and in the lavender blood collection tubes, we have disodium EDTA. So that's been used for decades as an anticoagulant. Therefore, it is a trusted anticoagulant. We know it works. Because of its strong binding affinity for calcium, it inhibits that coagulation cascade. And we know that it's effective against the gram-positive, gram-negatives, and yeast. And again, it is the only lock solution that has the capability of eradicating biofilm of all strains, including those of superbugs. KiteLock 4% has been regulatory approved for use in adults in Canada, in Europe under the CE mark, which also is allowing us to go into the Middle East countries, and as well as Australia. It is also the only lock solution that has gone through the regulatory hurdles, which are vast, in order for it to be approved for use in children. So just some history on how the evolution of KiteLock occurred, and some of the clinical data. Dr. Peter Kite, who is a microbiologist out of Leeds, England, and who we named the product after, it's why it's called KiteLock, was a microbiologist that was trying to reduce the infections that were occurring in dialysis patients. So he removed some of these catheters, opened them up, and found that there was a tremendous amount of biofilm inside these CVADs. He's one of the first clinicians to show that biofilms occur inside a catheter as well as outside of a catheter. Then he went to all of the different molecules on a shelf and found that tetrasodium EDTA at 4% was the most effective at eradicating and killing all different strains of bacteria and biofilm found inside these catheters. Then they conducted a randomized controlled trial in dialysis patients in the UK in 4 different centers with 117 patients. Again, because it's really hard to get that evidence on CLABSI as a primary endpoint because the rates are so low, they chose a bacterial colonization as the primary endpoint and showed 87% reduction of bacterial colonization in these CVADs. Secondary endpoint was CLABSI. Although it was not a significant difference, it did show a trend of greater than 50% reduction in infections. And then when it came to catheter patency, although tetrasodium EDTA did not perform as well as heparin in this study, they believe it was due to the fact that there was more extraluminal occlusions because heparin would seep into the patient's system and help alleviate some of those extraluminal fibrin sheaths that occur. So there was a higher extraluminal occlusions in the EDTA group, but they said that intraluminal occlusions were similar in the 5,000 units of heparin and the tetrasodium EDTA group. Then we had a Canadian study conducted in British Columbia on 20 patients who were previously on taurolidine, heparin, and saline, and they showed a 70% reduction in CLABSI. And all of the patients that ended up going into the clinic, they couldn't control outside the clinic because they didn't have hands-on to those patients, but the patients coming into the clinic had zero use of any thrombolytics. And the patients actually said over a period of time that they felt as good as they did the first day that that catheter was inserted. Whether that's because there's no bacterial infusion or toxin infusion because we get rid of that biofilm, we're not sure, but they did have that personal experience. And it also showed a 63% reduction in cost. Now they took this one step further, and patients that would go into emerge that had an infection, and they knew that the patient had their catheter locked with kite lock. They didn't pull the line, knowing that the infection was most likely not coming from the interluminal part of the catheter, it was coming from the extraluminal, and allowed them time to pause and look to see where the infection was coming from. Then we had another study conducted in children at Toronto Sick Kids on 20 patients, kite lock versus half the group that was previously on heparin and half the group that was previously on ethanol. Now the transition for Sick Kids was they went from all heparin to ethanol. They showed about a 50% reduction going to ethanol, and then they showed another massive reduction going from ethanol to kite lock, in that they showed a 100% decrease in infections and a 50% reduction in Alteplase use. And because these bodies were small and they couldn't afford for the lock solution to be aspirated on a daily basis because of the risk of being anemic, they prolonged the study, and they started to flush the lock solution, kite lock, into the body versus aspirating, monitored their calcium levels and their bone growth levels, and neither of them were impacted. They were safe and no changes. Again, we took bacteria from 300 catheters in Ontario, as well as the bacteria from catheters in Saskatchewan. And one of our world-renowned infectious disease labs in Saskatchewan grew these biofilms and put tetrasodium EDTA at 4% to make sure that we're still able to break down these current strains of bacteria. When we brought tetrasodium EDTA to these biofilm experts, they kind of laughed at us and said, whatever, it's EDTA. And they now call it their gold standard, that it's liquid gold. The results that they're seeing on biofilm are blowing them away as well as us away. It's way more efficacious than even we thought it was going to be. Again, it's important to understand the different capabilities of the different bacteria. The gram-positives are very hardy and difficult to break down. The gram-negatives have a very strong bacterial outer membrane, which is very hard to penetrate. And then yeast, of course, is our biggest, most difficult ones to get rid of. So the concentration that it takes to kill some of these bacteria or eradicate the biofilms gives you an indication of how hardy some of these strains are. And they need the absolute 4% to get rid of them. Then the time of exposure is also dependent on the hardiness of that biofilm and how long it takes to eradicate them. And we show that within 24 hours, we can eradicate all of the different strains, no matter how sturdy they are. And this can be done in an accumulative effect, that if you only can lock them so many hours per day, that over time it will break down that biofilm. It's also important to remember that there'll be multi-species in these biofilms. So just because we test and we know that there's one bacteria in there, there may be multiple, so that it will take time to reduce that biofilm that's present inside these lines. That's why it's important that they're on kite lock 24. Use kite lock as your standard of lock solution. So of course, cost drives care when it comes to financial evidence. A value-based procurement project was done in a hospital, Ontario. They developed a return on investment, which is available to any of you if you want to put the data that you currently have in there to know if kite lock is being cost effective for you or not. The one thing I like to point out is under the guidelines, they reported 0 infections because we only look in the ICU. What they found is that there was 14 confirmed infections, but 83 suspected. So it's important when we're reporting our infection rates that we know whether there's confirmed and suspected infections, and we're capturing both to truly know what we're trying to deal with. And that they only needed to reduce the complications by 7% to be effective and to reduce the cost that it would take to procure kite lock. Currently with the regimes on citrate and Alteplase, the cost for that regime is about $134 a week. If you're using kite lock, the cost is $36 per week. So that's 75% less than what that citrate lock regime costs. And the cost of one CLABSI is equivalent to a patient being on kite lock for 8 years, or the same cost as 7 patients being on kite lock for 1 year. I'm slowly wrapping it up here now. I just wanted to talk about this briefly. According to the Kadoki guidelines and this study that was done by Hamelgarn in Canada, the protocol of the heparin and TPA lock showed that they had a decrease in infections, which I try and wrap my head around why TPA and heparin would reduce infections, but also reduced the CVAD dysfunction rate compared to heparin alone. The only thing I can think of is between stopping clots from happening and breaking clots down, you remove that nutrient plasma protein equation from it, which slows down the biofilm formation, which can impact both your dysfunction and your infection rates. Then we went away from heparin and converted to citrate and TPA lock. And what we're hearing from the dialysis programs in Canada is that the Alteplase use has gone up exponentially year after year. So why is that? Is it because citrate doesn't work as effectively as heparin, so that clot component is more present, and that biofilm component is still present as well? So you have both of those factors that cause occlusions that are still in the equation of the interluminal aspect. What we're seeing with kite lock, and what Dr. Ouellet will speak to, is when kite lock is implemented, it's reducing that need for TPA use dramatically. Is that because we are the only lock solution that can stop all 3 of these gears occurring? We can take out the biofilm factor as well as the clot factor, and only use TPN when necessary if that clot's forming during dialysis. I'll let him speak more to that. So that's just really a theory out there. Why is this occurring, and is there something that we can do differently? And is kite lock showing better performance than what's currently being used? So my last slide is to really turn this back to all of you, experts in this field. Based on current practices and knowing that most of them are based on expert opinion more than evidence-based, does the evidence and the science that we're presenting you today give you comfort to try and make change? If Alteplase use is going up exponential every year, do you have anything to lose by trying kite lock to see if it can impact that amount of Alteplase that you're using? Is the risk-benefit ratio there, and is the cost savings there? The next thing I'd like to put out there as a thought is, if kite lock does have that capability of eliminating that triple threat and reducing these complications, can you get back to a place where you can put an Alteplase algorithm in, where if the standard lock solution is kite lock, if you need to use Alteplase, and after 1 or 2 doses, if the dysfunction is not resolving, is that because it's an extraluminal factor, not an interluminal factor? So does that stop the desperation practice where we just grab Alteplase because that's what we do when there's a dysfunction, and use it once or twice, stop using it, and then go and try and figure out what else could be causing that dysfunction if we know that the interior of that line is being protected? The next thing I want to have people think about, and Dr. Ouellet will touch more on, is blood flow rates. Because we're only using kite lock in the most difficult, complicated CVADs that are having problems, we still have not seen a dramatic impact on blood flow rates. So why is that? Is that because it's being introduced too late and there's too much extraluminal factors that are still at play? And what would happen if we use kite lock longer? Would that reduce blood flow rates? Or if we put kite lock into the interior of that CVAD when the patient is first given their first catheter, because of the osmolality of kite lock and the osmolality of blood, could we eliminate the development of complications at the tip of that catheter and see these blood flow rates sustain themselves for a longer period of time. That's just a theory that I'm throwing out there based on the science, and would love for someone to test that if possible. And then, of course, we always want more publications and more data collection. So if anybody's interested in doing this and is collecting this work, if we can either collaborate together as experts to do some publications or do them on your own, that would be greatly appreciated so that we can share our findings with the rest of the world. So on that note, I'm going to pass it over to Dr. Ouellet, who will share his experience with you now. Dr. Ouellet, it's your turn.
Yes, I'm still here. So, well, thank you for the introduction. So I'm just going to share my slides with you. So you can see my slide now.
Yes, we can. Thank you.
Okay, good. So, so thank you. So I'm going to show you about what we experienced with tetrasodium EDTA when we used it in a group of patients with dysfunctional catheters. So first, some disclosure. So I received funding from Sterile Care to help with the data collection and the database cleanup. After this, we did our local experience with KiteLock. And just to mention as well that the KiteLock vials that we used were actually bought by our own hemodialysis program from a medical supplies and equipment distributor. So I'll just start by giving you a profile of the hospital where I'm working and the dialysis program in our center. The current use of Alteplase in our hospital, and then I'll show you the data that we got when we used KiteLock in some of our patients. So I'm working in Hôpital Maisonneuve-Rosemont, which is, as you can see, located in the eastern part of the island of Montreal, and it's part of a larger structure called a CIUS, which is like an integrated system where you have physical health hospital, a mental health institution, you have long-term care facilities, community clinics. So this structure is caring for more than 500,000 people, which is a little more than a quarter of the total Montreal population. And as you can see, that's a population with some challenges, like it's an aging population, and we have also a high burden of comorbidities. So this is a hospital that was founded in the 50s, and it's a teaching hospital that is affiliated with the University of Montreal. We have more than 600 beds on the permit. And the main areas of research in our center are in hemato-oncology and stem cells therapy, ophthalmology and eye health, and nephrology, as well as renal transplantation. So our dialysis unit is located on site. So this is in-center dialysis unit that is attached to the hospital. We don't have a satellite unit. And that's a large building that the new building was opened in 2019. We have 70 treatment stations, as well as 4 home HD training stations, and we're caring for over 375 in-center hemodialysis patients, 72 PD patients, and around 30 home HD patients. So that's quite a large population. The profile of our dialysis population in terms of vascular access, you have here the proportions. So as you can see, we have a very high number of catheters. Almost 60% of our patients are dialyzing with a catheter. what you see here is data that comes from the annual report from the National Health Institute of the province of Quebec. So this is from the annual report on the nosocomial infection. And this is related to the dialysis-related bacteremia. So the first, on the first part of the slide, you can see you have all the different dialysis center in Quebec, and that's basically the size of the center. So that's on the y-axis you have the number of patient month. So that's the largest center in Quebec. And on the second slide, you have the incidence rate of catheter-related bloodstream infection reported by 1,000 catheter days. So as you see, that's a large cohort, but we're quite happy to have relatively, I would say, acceptable rate of catheter-related infection. So a real problem that we have, although, is the use of Alteplase, which is quite a lot. So our standard lock solution is sodium citrate, and we're using pre-filled 3 milliliter syringes, a volume that is a little higher than the lumen size is instilled in order to attain the tip of the catheter. And regarding the use of Alteplase, it is done through what we call a collective order, and the nurses have different scenarios in which they have the indications to use the Alteplase, whether it's at the opening of the catheter or if there's dysfunction during the treatment. You have here the criteria for a dysfunction during the HD treatment. I guess it's pretty much standard compared to what you have in your centers. So these are like the criteria that the nurse are going to refer to in order to use or not the Alteplase if a catheter is considered dysfunctional during HD. And you have here a screenshot of the algorithm that the nurses are using. So if the blood flow is insufficient and we expect to have an online KT/V below 1.2, the nurse will have to reverse the line after doing the usual non-pharmacological procedures like asking the patient to cough or to change position and so on. So if while you reverse the line, the nurse is not able to obtain a blood flow below over 300 and the KT/V is below 1.2, this protocol asks to use Alteplase as a lock treatment for two consecutive treatments. And then if the performance of the catheter is appropriate, then the Alteplase will not be used. So as you can imagine, this leads quickly to a lot of Alteplase being used. And we also have some, of course, we have some patients who are locked once a week with Alteplase because they have catheters that are known to be dysfunctional, and some of those patients are locked once a week before the long interval with the Alteplase, which is something that is also suggested now in the new version of the KDOQI guidelines about vascular access. So just to give, as it's been already mentioned, a vial of Alteplase is priced $65. That's the actual price that we are paying in our center when we buy it. And just to give you idea, that's the kind of costs in terms of Alteplase that we have in our dialysis program, considering the size of our population. So that's over 7,000 vials per year. So that's quite a lot. So that was one of the reason we were interested to try KiteLock in our patients with dysfunctional catheter. So the initial goal was just to use it and get experience with it to see how we were able to use it and have the impact that we would be able to get on maybe the use of Alteplase. So initially we chose 10 patients with tunnel catheter that were considered dysfunctional. So those patients were patients that were already locked with Alteplase once a week before the long interval. And what we did was to switch them gradually to being locked with KiteLock. So so they were at first locked twice a week with citrate and once with Alteplase. So that was their usual prescription. And then over 2 weeks, they were locked with EDTA twice a week and with Alteplase once, and then they were switched completely to tetrazodium EDTA. So what we did was to collect retrospective data for 3 months before the switch, and then the data after that switch in the lock solution was done. We looked at our use of Alteplase, blood flows, arterial and venous pressures, the need for line reversal. We looked at the average weekly KT over V measured online from the dialysis machine, and serum electrolytes. And of course, our goal was to see the impact of tetrazodium EDTA on our use of Alteplase and on catheter function. So here you have the data for those first 10 patients. So that's the number of times per month that Alteplase was used at the end of a treatment. So that's the average number over the 3 months before we make the change, and then over the 3 months after we made the change. So you see that we reduced quite importantly our use of Alteplase from an average of 4 times a month to 1.6 times a month, and as you see, that was statistically significant. In terms of the other parameter of catheter function, namely line reversal, blood flow, and pressures, there were no changes. KT over V remained the same, as well as calcium, magnesium, potassium, sodium. These are the electrolytes that we looked. So no statistical difference, or not even a trend for a change. So graphically, that's what you can see. So this is the period where patients were locked with citrate twice a week and with Alteplase once a week. So you can see that the average use of Alteplase was 4 times per month. And you see that as we are using tetrazodium EDTA, there's quite a reduction in the number of times that we are actually using the Alteplase. So, as I mentioned, our initial goal was to look at 10 patients, but interestingly, there was kind of kind of a glitch with the order when we actually ordered the KiteLock vials. So we ended up having much more vials that we were initially expecting. So we had to add more patients to continue this experience. So the 12 more patients that we added was a little more heterogeneous group. So we had some of those patients that were locked once a week. We also had patients that were not necessarily locked once a week, but were like frequent users of Alteplase. And also we included some patients with catheter that were newly becoming dysfunctional. So same parameters here. So here that's the 22 the data from those 22 patients. So what you can see is that once again there's a significant reduction in our use of Alteplase. So from 3.9 times per month to 1.6. In terms of function, as you can see, there's a little reduction in the blood flow, which is statistically significant. We could argue whether it is clinically significant, a reduction in 9 milliliter per minute. But what is reassuring is that the KT over V did not change at all, and it was no statistical, no changes in KT over V. And once again, no changes in the electrolyte. So here again, you can see the evolution of the use of Alteplase. So this is the average monthly number of average number of times Alteplase was used to lock a treatment. So you can see that it goes from around 4 to around 1 time per month. Here you can see the number of times that the patients were locked with Alteplase that really dropped. Of course, there's an attrition in our for the long as the study go, because we did not have the same length of observation for all of our patients. Here it's just that just to show that changing from citrate to KiteLock reduced the use of Alteplase, and that the effect was continuing over time when we do that mixed model analysis. And here, this is absolutely not meant to be a pharmacoeconomical study, but just to show what was the cost in terms of Alteplase, because here it's the number of times that patients were locked with the Alteplase, but you need 2 vials to lock a catheter. So these are what we spent during these months in terms of Alteplase. So that's we can see that there's quite a reduction if you compare what's comparable. So the first 3 months and the last 3 months here, you see that there's quite a reduction in the amount that is spent on Alteplase. So as I said, that was like a more empirical observation that we did. So that was actually well accepted by the patients. They were not especially concerned with using a new lock. It was well tolerated by the patients. No adverse effects were reported. It was well accepted by the nurses as well, though I have to mention that it was a little more time consuming for them, because they had to prepare the syringe, contrary to the citrate, which is served in pre-filled syringe. So a little more manipulation, but I mean, that was well accepted still. And this is very qualitative data, but there's a nurse that went through 16 charts of patients after they were returned to citrate, because when we exhausted our stock of tetrasodium EDTA, we returned all the patients to citrate, to being locked citrate with citrate 3 times a week. And in the month after that that return to citrate, for half of the patients there was a reduction in the blood flow and the online KT/V. It was stable for 5 patients, and interestingly, there was 1 patient with an increase. And also, interestingly, in the first week after patient stopped using KiteLock, 7 of them had received Alteplase at least once. So quite rapidly after the KiteLock was stopped. So, I mean, we discussed a little bit about Karen presented about the mechanisms in her part. So, yeah, what was the mechanism for what we observed on our use of Alteplase? It was because in those patients with dysfunctional catheter, the anti-biofilm effect reduced the intraluminal clotting, or was the dysfunction due to the biofilm itself instead of intraluminal clot? That's something we could speculate on that. And the other possibility, because as well, the other possibility is that those patients, as I said, we reduced, as I showed, we reduced the use of Alteplase, but we maintained similar catheter performance. So, were those catheter not so dysfunctional, and were we using Alteplase inappropriately in the first place, or the dysfunction was maybe extraluminal as well? So that's another possibility. So in conclusion, for our 22 patients with dysfunctional catheter in which we try the sodium EDTA, we obtained similar catheter performance, but with less Alteplase. We had no impact on serum electrolytes, which is reassuring. And this was an intervention with potentially significant savings for our hemodialysis program. So that's it. Thank you.
Thank you very much, Dr. Ouellet, for full transparency. For the folks on the line, for both myself and Karen, that's actually the first time we've seen Dr. Ouellet's data. So I want to be very transparent with the fact that what he just presented was the first time all of us are seeing that, which is great for us to see that KiteLock is working. For the interest of time, I'm going to open it up. It is 2 o'clock. I'm hoping you can stay with us. I'm going to open up the line. If you'd like to ask a question, please unmute yourself. This would be a great time to ask either Karen, myself, or Dr. Ouellet any particulars that you have.
Hi, my name is Patty Quine, and I'm the Vascular Access Coordinator at Humber Hospital in Toronto. And I was just wondering during the trial at your study in Montreal whether there was overfill on the KiteLight volume as well. You mentioned something about if the lumen volume was 1.8 or more, that there was 2.5 of sodium citrate instilled. And I'm just wondering with the KiteLock if there was an increase in the volume beyond the lumen size.
Yeah, that's we did not. Yeah, you're correct. For citrate, if it's 1.7, we rounded up to 2, and if it's 1.8, we rounded up to 2.5. That's with citrate. We've been a little more conservative with the EDTA, so it was lumen volume plus 0.3.
Okay, thank you. And just for Karen, is that in the other studies that you presented as well, that they do a 0.2 or 0.3 overfill for KiteLight?
Yeah, what we say is whatever your current guidelines are, they are the same. You use Kite Lock with the same volume that you would use any of your other lock solutions.
Thank you.
Yeah.
Thanks, Patty. Anyone else?
Hi, it's Daphne. I have a question for Dr. Ouellet. Given these results, I'm wondering if your organization has changed your practice and implemented the use of the Kite Lock. And my second question would be, was a protocol to aspirate the Kite Lock or to flush it through?
The second question is easier to answer. So we would aspirate. The first one, not yet, and but it's, I think it's something that that we have to. I'm definitely interested to have this product on our armamentarium in our program. The reason it's not done yet is that we actually moved into the beautiful building that I showed on the slide, which was very time consuming, that and also something called COVID hit quite strong in Quebec last spring. So that's something that was put aside a little bit, but that's something that we plan to do, to have it on our formulary.
And if I may, one quick follow-up question. If you do make that transition, would you use it as the standard protocol, or would you use it for high-risk patients who perhaps may be recurrent, patients with recurrent infections?
At the moment, I would say practically, it would be difficult to do it across the unit. Because of the need to prepare the syringe. That would be, I think, in terms of nursing, that would be a challenge to do it all over the unit. So the introduction, I think, would be with the difficult patients.
Thank you.
For us, I mean, until it is, you know, pre-filled syringe, that's something that could be reconsidered.
We actually have a question on the chat line in regards to that as well. So as a small Canadian startup company, it was more cost effective to put it in a vial, but we understand that the market wants it in a pre-filled syringe. So we are looking at putting in a pre-filled syringe. We've already started the process to do that, but it's a bit of a catch-22. We need the volumes to go up in order to warrant the cost that is going to put in a pre-filled syringe. And also when the volume goes up, the Kite Lock cost will come down. So that's where our intentions are, is to come in a pre-filled syringe and to try and reduce the price per unit over time, depending on volume. So hopefully that answers some of your questions.
Thanks, Daphne. Anyone else have a question for Dr. Ouellet or the company?
There's a question on the chat that says, I may have missed it earlier, but what's the cost for one EDTA? One EDTA vial, the list cost, depending on your volumes, it starts at $6 per vial. Next question is, do we just aspirate the dose or do we need to mix with sterile water? You just aspirate the dose. When you mix it with sterile water, you change the concentration of Kite Lock. So you don't want to be mixing it with sterile water.
And Karen, it's Patty from Humber Hospital again, just asking, so $6 a vial, that means times 2, so it's $12 for a treatment?
Correct, that's right.
Thank you.
Anyone else? We've got about 60 people on the call, so I'll take the time just to fill in here. If you do have any questions, I think Karen, you
I have a question.
Oh, hi, Megan.
Hi, sorry, it's Megan from Alberta Children's in Calgary. I'm a hemodialysis nurse here. So I'm just wondering, I know you mentioned they did a small trial at sick kids, and wondering if they are using KiteLock or if any other pediatric centers have looked into using it or trialing it in peds. We use Alteplase to lock all of our lines all the time.
Interesting. So Toronto Sick Kids initially started their trial in their GIFT program, their parental nutrition children, and they are now using it, implementing it hospital-wide. So they'll be using it on all of their different catheters and all of the different patient populations. And then we have various children's hospitals across Canada that are using it, and I believe your back door is using it as well in the parental nutrition program. Within your hospital, yeah.
Oh, okay. I didn't know that. All right, that's good to know.
Yeah.
Thank you.
You're welcome. I can give you the study if you want to. Just contact Sean or myself, and we can send you over the study that I spoke of.
Yeah, I think that would be really interesting and relevant. Thank you.
Okay.
So someone actually asked me, I just realized that it was asked privately. So someone asked me if we monitored the infection rate when using KiteLock. I did not mention, but there were none in those patients while they were on KiteLock.
Thanks, Dr. Ouellet, for that. I did leave my email address in the chat if anybody needs that. Another question is, how is KiteLock stored, in the fridge or the med cupboard? Room temperature. It doesn't need any special storage.
I'll use this time just to let everyone know if there are studies that you'd like us to send you. Karen and I provided you our email addresses there, so please reach out. I am working, or have discussed this with some of you. If you also feel as though you'd like to have a session that's more geared towards your specific hospital site, please let me know. Karen and I can provide you with another Zoom invite and go over more details if you wish. So we're always there for the studies or additional invites. So Clara had asked if it comes in a multi-dose vial. So the vials are for single use. They come in 3 ml fill volumes, just let you know. They are luer locking vials, so that when you do twist off the tab at the top, you can luer lock your syringe to withdraw the contents of the vial. Karen's holding up a box of KiteLock there. Karen, can you show them a quick individual? So this is the individual eaches that you would receive. And when you, again, twist off that top there, that's a luer locking mechanism at the top of the vial.
So we have one home TPN patient using it, and she aspirates it. Does she need to continue to aspirate it? So this is a double-edged sword answer. According to all regulatory bodies around the world, when you use a lock solution, the reason why they mandate that you aspirate versus flush is because as that lock solution sits inside that catheter, you will get the loosening up of clot fragments and biofilm fragments and bacteria. So they don't want you pushing that debris into the patient's body. But of course, we know that that isn't always common sense or practical in certain situations. So when it comes to KiteLock, there is a large margin of safety. You can flush versus aspirate, and we do have patients that have been on it for more than 4 years that are flushing every day because they cannot aspirate and they're not having any issues with calcium serum levels or adverse events. Hopefully that answers your question.
Yeah, I'll just add there, Karen, that is the data that was researched and monitored at Sick Kids Hospital when they were doing their trial. So again, they were pushing KiteLock into those patients, those pediatric patients, without any complications or adverse events. So again, just want to stress that that's on pediatric population. So we would not anticipate any complications with the adults, in theory. And I think Karen had mentioned it, but just again for a highlight, just to let you know that again, KiteLock is the only Health Canada approved lock solution on the market today. So I think that's important.
For use in children.
For use in children, that's correct.
1111, lucky number. Any other questions, especially for now that we have Dr. Ouellet on the line with his expertise?
Yeah.
So I would like to thank Dr. Ouellet for presenting your information today. Very well done. As Sean said, first time that we've seen that presentation, so excellent results. I'm very happy to see that. So again, thank you for your time and effort to present that to everyone today. I would also like to extend a massive thank you to all of you frontline care workers that are working in protecting us during COVID-19. Always applaud everybody for your efforts. I know it's not easy and it's hard enough for us at home. I can't imagine what it's like for you guys in the front line. So if there's no more questions, thanks Sean for organizing this webinar, and I hope everybody has a fabulous holiday season. Stay safe, stay sane, and stay well.
Thanks, Karen. Yes, we will be sending out this presentation at a later date as well, just so you know, and I'll make sure I relay that to all of the attendees. Thanks, everyone. Have a great day.
Thank you.